Hello, this is Dr. Bhomik, and today I'm going to talk to you about neonatal endocrine emergencies. Many of these emergencies I have already discussed in separate lecture, but today I'm going to discuss the neonatal hypoglycemia during the neonatal period and beyond infancy and childhood. However, I do realize that this is a very humongous topics, so I will not be able to cover everything in details. Let's review what are the endocrine emergencies. Well, one of the most important one is neonatal hypoglycemia, neonatal hypocalcemia, which we should be discussing in future lectures, and ambiguous genitalia. We have already discussed congenital adrenal hyperplasia. We have also discussed, and this is in my previous videos, are ambiguous genitalia, neonatal thyrotoxicosis, congenital hypothyroidism, as well as inborn error of metabolism, which has been discussed in two parts, part 1 and part 2. So now today we are going to focus on hypoglycemia. Now, most important thing that one need to realize the definition of hypoglycemia, and which, as you will go through with me with the lectures, that there is some controversy about the number. However, the working definition of hypoglycemia in a term infant is blood glucose less than 40 milligram in first 24 hours and less than 50 milligram thereafter. However, in premature babies, it is most of the people agree with this number is blood glucose less than 35 milligram considered low, and the difference of the opinion, as I have said, that do exist about the number. However, I am not too concerned about number like 35 or 37 or 42 or 38. But what is most important is not how low is the blood sugar, how long it has been low. So duration of low blood glucose is much more important than fixated only one number. So the practicality is that confronted with a hypoglycemia, first of all you have to confirm that it is hypoglycemia. Controversy of the definition, as I have said, and blood glucose concentration varies randomly in different categories of the infant. What by that I mean appropriate gestational age infant definition of hypoglycemia is going to be a little bit different than a small for gestation baby, premature babies, twin babies, and so forth. So the most controversy that has been in the first few days of life. And one of the things that one need to consider is that when we are talking about the plasma glucose, which is about 10% higher than blood glucose. Signs symptoms of neonatal hypoglycemia. It is wide varieties of the symptoms that one can see, from abnormal cry to tachypnea. So it is in these slides, and all of this or few of these combination of these things can be manifested in any given babies. But it's nice to know the symptom. So which neonates is at high risk of developing hypoglycemia? We all know about the small for gestation. We'll expand on a little bit on that, as we go through this presentation. Prematurity and the twin babies. If the patient has hypoxia, cold stress, and everybody knows about this one, is the infant of diabetic mother. But in order to make the discussion somewhat complete, not all fully complete, somewhat complete, I just have to add some of the rare cause, which is rare, of hypoglycemia in the newborn period, and they are inborn error of metabolism. And again, this has been discussed. Back with Wiedemann syndrome, and this is the big babies, and the basis of hypoglycemia is appeared to be hyperinsulinism, RAS incompatibility and excess transfusion, which is a rare cause nowadays, especially the RAS incompatibility. We take care of them beforehand. And maternal toxemia, drug ingestion, and especially if the beta blocker has been given to the mother. And as we all know, the beta blocker blocks the epinephrine, which is the fast and the most important hormone to increase the blood glucose. What about hypoglycemia in prematurity? We do know that glucose production rate or turnover rate is higher in premature babies, which is about 5 to 10 milligram per kg per minute, as opposed to a term baby who makes about 3 to 6 milligram turnover rate kg per minute. So the demand for the prematurity seems to be higher glucose demand than the term babies. Poor glycogen storage, but one need to remember the reason that poor glycogen storage is that most of the glycogen storage occurs at the last trimester of pregnancy. Suboptimal gluconeogenesis, and these are the babies are also premature babies are more likely to be stressed. So let's talk about the one that we all know. These babies, the mother has diabetes and born, and these are the infant of diabetic mother. The reason is the most important cause is the transient high insulin level. The infant of diabetic mother suffers more of hypoglycemia if the mother's diabetes control was not that great. The high blood glucose from mother is pushed through the placenta to the baby's circulation. And so baby then has to produce more insulin by his or her pancreas to combat the hyperglycemic state. And when the insulin is high, obviously, there is a suppressed gluconeogenesis and glycolysis. So now I'm going to talk a little bit about the persistent hypoglycemia in infancy, childhood, and beyond. So this is a persistent hypoglycemia. I'm talking about these are not transient. The number one and the one that we always worry is hyperinsulinism. The next comes the hormonal issue related to the pituitary, hypopituitarism. Then the metabolic disorder, almost all amino acid metabolism or glycogen metabolism are associated with acidosis, and as I have mentioned previously in my metabolic lectures, and they are hypoglycemic and acidosis, and fatty acid oxidation defect. So some of them are rare and some of them are not as rare and also very concerning. This diagram I have made myself just to express the four arms of hypoglycemia. So the four arms I mean is here is hyperinsulinism, here is endocrine cause, hypopituitarism, and here is the metabolic cause, and here is free acid oxidation defect. Okay, so this diagram will tell you the salient finding of these four conditions. So let's talk about free acid oxidation defect. And in order to make the diagnosis, you will have a high free fatty acid and there will be no ketone. But let's look at the hypoglycemia and look at the pituitary response. If the patient has hypopituitarism, we will have very low cortisol and the growth hormone. And this is a very important finding because there is no stimulus. I repeat, there is no stimulus is greater than the low blood sugar to increase or stimulate the secretion of growth hormone and cortisol. So in the presence of hypoglycemia, low cortisol and low growth hormone is almost diagnostic of pituitary hormone deficiency. Now let's come to the metabolic cause. So in your residency, or you will have heard that your neonatologist is saying that we collect the critical sample when the baby is present in the emergency room or inside the nursery. When this baby has hypoglycemia, we collect the critical sample. What the critical sample means that even if you forget what test to order right away, but if you know the causes, so this, then you can sit down and look and then decide what test has to be ordered through the critical sample. So if we have a metabolic defect, pyruvate and lactate level will be high. If this is high, this is a very diagnostic of hypoglycemia related to the inborn error of metabolism. And so as the free fatty acid level, carnitine, lower carnitine level and absence ketone also is very suggestive and of fatty acid oxidation defect, and low cortisol and growth hormone for endocrine problem like hypopituitarism. And now let's come to the insulin. Hyperinsulinism is the big one, and this is the one we worry significantly. So critical test for that is obviously insulin C-peptide, and there will be absence of ketone. But also remember that an infant may not make as much ketone or ketone production in infant, and especially the newborn period may not be that efficient. But there is one thing we do is called glucagon challenge test, and some places they are not doing it. But what is the definition of glucagon challenge test, I will discuss in my next slide. So diagnostic criteria of hyperinsulinism. This is most important criteria. Now, in order to maintain the normal glucose level, maintain the normal glucose level or keep the baby euglycemic, if you have to infuse glucose 10 to 12 milligram per kg per minute, 10 to 12 milligram per kg per minute, there is hyperinsulinism. There is no if and there is no but. There is hyperinsulinism. What is the etiology of that hyperinsulinism? That we need to figure out. So high glucose infusion rate to maintain euglycemic or to even still the hypoglycemia cannot be controlled, is a very ominous sign and finding that this is hyperinsulinism. We also know the insulin is a growth factor in babies, and these babies are large for gestational age, big babies. And then one test that was popular, and some nursery do it, some don't, but it is important to know that this is an old test called glucagon response. If you measure the blood glucose 30 minutes after a glucagon administration, the usual dose is 0.03 milligram per kg. If you give this one IV or IM, for that matter, IV or IM, and if you can show that the glucose response has been more than 30 milligram above the number that you started with. So say for example, the blood glucose is 30, and you keep the glucagon and blood glucose has gone up to 70, 80, that's a positive glucagon test, and that suggests hyperinsulinism. So 10 milligram above the baseline. The insulin level. Again, there will be little controversy. The one that I learned or I read from many textbooks is any level of insulin 4 or above in the face of hypoglycemia is very, very abnormal. So that's high insulin compared to the level of the blood glucose. So, and some people will say any level of insulin, any insulin even 1, 2 is suggestive of hyperinsulinism. So I'm not too worried about that. Whatever is your criteria, but the presence of insulin 4 or so, the face of low blood glucose, is one of the very important diagnostic criteria. And as you know, the hyperinsulinism prevent the breakdown of the ketone, and so if there is a ketonuria or ketonemia, is another point towards the diagnosis of hyperinsulinism, and you should have normal lactate, pyruvate, cortisol, growth hormone, or any other hormone that you have tested. So, what are the etiology of hyperinsulinism? I like to emphasize here, hyperinsulinism itself a lecture, and hyperinsulinism is something I cannot cover within this short period of time. I'm just going to give a little bit of outline. A cause of hyperinsulinism could be beta cell hyperplasia, adenoma, or this what we call congenital hyperinsulinism, and the previous name was nesidioblastosis, is no more there, but this is congenital hyperinsulinism. Older time was known as nesidioblastosis, but I want you to forget that one. But congenital hyperinsulinism and the mechanism of insulin secretion. Our paper, we published one paper with the review of hyperinsulinic hypoglycemia with some case report, and the mechanism of hyperinsulinism is discussed there, and it was published in Clinical Pediatrics. Infant of diabetic mother, Beckwith-Wiedemann syndrome, and malposition of umbilical arterial catheter, and if the patient had insulin-dependent diabetic baby, there is a dose error, and the child abuse has been reported by giving too much insulin. And again, if you measure the insulin level, which will be high, but C-peptide will be depressed, because each molecule of endogenous insulin secretion is with C-peptide. So C-peptide and insulin together. So measurement of C-peptide is the most important test to rule out exogenous insulin use. So treatment of hyperinsulinism is briefly is obviously you have to continue to give insulin glucose as much as you can, which is about 10 to 20 milligram per kg per minute. But when you stay more than 16 milligram per kg per minute, you need to look for other modalities of therapy. And the first line comes with the diazoxide. The dose is about 10 to 30 milligram per kg per day, and it divided in about 3 divided doses every 8 hours. Somatostatin or octreotide has been used, and if nothing works, then subtotal pancreatectomy is the last resort that has been used as well. Now let's talk a little bit about hypopituitarism. And if you have hypoglycemic baby and you happen to check the critical sample and happens to check the glucose, growth hormone and cortisol, and if you see the growth hormone response is less than 10 milligram in the face of hypoglycemia, and cortisol response less than 5 microgram, and 5 microgram less than 5 is rather diagnostic, less than 10 microgram is suggestive. So therefore low cortisol response, low growth hormone response is the most critical finding in hypopituitarism. And there is, in the question section, I have also discussed that microcephalus with hypoglycemia is also an indicator or a suggestion for hypopituitarism, and sometimes they are a symptom complex part of the condition called septo-optic dysplasia, optic nerve hypoplasia. And in the newborn period, when you go and examine, there will be horizontal nystagmus, eyes going everywhere, back and forth. And so the three modalities combination, microcephalus, hypoglycemia, and nystagmus, horizontal nystagmus, is the omnivorous sign of hypopituitarism. Metabolic cause has been described in two-part series of lecture, and here it could be the disorder of the glycogen metabolism, gluconeogenesis. There could be specific enzyme deficiency, as we have discussed in galactosemia, and hereditary fructose intolerance, and error in amino acid metabolism, which has been discussed rather extensively in the metabolic lecture. Again, this one is the repeat of the previous one, is the diagnostic criteria that I have given you. Next is defect in fatty acid oxidation, and in this criteria will be primary carnitine deficiency, and that is carnitine palmital transferase 1 deficiency and acyl cohydrogenase deficiency. So this is a very highly specialized in metabolic field. So I just want to mention, and you really don't have to worry too much about this. But remember, the primary carnitine deficiency is the one is a big problem with defect in acid oxidation. So, in order to complete the diagnostic section of metabolic area, I'm just going to quickly go through that finding that one will have. And these are the normal growth hormone response and suppressed insulin level during hypoglycemic episode, a normal cortisol response to the low blood glucose, absence of ketone and ketonuria, elevation of free fatty acid, and decreased serum carnitine level. So serum carnitine is the test that we do very frequently to rule out the fatty acid oxidation defect, and then we look for the organic aciduria. And this one is again a little bit repetition and summarization. So in neonatal hypoglycemia, beside adequate IV glucose infusion, if one cannot correct it, then the glucagon can be given as a diagnostic as well as therapeutic test. One can use hydrocortisone, and that if the baby has got hypoglycemia secondary to hypopituitarism, it will respond better. Sometimes we may have to do that before we get the appropriate diagnosis, because hypoglycemia, and if it is persistent, it affects the brain, and the brain matters, and that's why sometimes we have to go through the treatment process without having the exact diagnosis. So these are the one that one can do: glucagon, hydrocortisone, and then if nothing works, then diazoxide, somatostatin analog, and by the time we go to the subtotal pancreatectomy, we will have a diagnosis of hyperinsulinism.